who had the vision for this 15 years ago. And we thought we'd feature the work of our Global Spine Journal, which is now over 15 years old, which is a unusual and I think very unique global collaboration of multiple specialties on the subject of spine. And in recognition of that work, we thought we'd focus on some articles from that. We had a great turnout, we had a great global audience, and again, I want to thank AO Spine International for doing this. And so to keep the momentum going, we thought we'd do this quarterly. We would, after we return stateside, pick up the slack. And it is great to actually have Dr. Karsten Weichert be the moderator who selected the articles for this. And we have reconvened our two great USC fellows and two of our great fellows to kind of run through 4 articles today. So we thank all of you for being here. And so technically we said this is live from Seattle, but the real thing should say live from Hamburg, because that's where Dr. Karsten Weichert is, co-editor-in-chief of Global Spine Journal and director of the Spine Center in Harvey there. In Hamburg. Karsten, good afternoon to you in Hamburg. So live from Hamburg, passing the microphone off to you.
Yes, good afternoon, Jens, and good afternoon to everyone around the world. I'm very happy to be there and honored that we're able to continue with the Global Spine Journal Club. And thanks to the Seattle Science Foundation, and on behalf of Jeff Wong and Jens Chapman and myself, we're the editors-in-chief of the journal. And yes, we're trying to cover everything spine. We want to take up this very special occasion on June 7th to congratulate our managing editor, Ms. Danielle Levan-Kiewel, to her birthday today. And I don't know if she's up and running at this time of the day, but we're certainly proud to have her. And yes, today we picked a variety of topics all around the non-operative aspects of spine care. And yeah, we're very proud and honored, and I personally am very thankful that we have 4 esteemed panelists who looked into these articles and give us a little bit of an overview. Yeah, I want to kick things right off with Dr. Anderson, and he'll be giving us insights about the association of MRI findings and long-term disability in patients with chronic low back pain. And yeah, happy to hear.
Hey, good morning. Yeah, thank you for that introduction and of the paper as well. This was a prospective longitudinal cohort study of about 13 years that was published out of Zealand University Hospital in Denmark by, and I apologize for the pronunciation, by Doctors Maharab and Anderson. That's an easy one. And this was in Global Spine Journal 2021. So as they discussed in the paper, MRI can be used to evaluate a multitude of things, degenerative disc disease, facet joint disease, motor changes, and even neurologic stenosis throughout the spine, in addition to other things. And then previous literatures looked at this, and it correlates well with acute symptoms. In their paper, they said the purpose of this study was to assess whether baseline MRI findings indicating degeneration are associated with long-term disability in patients with low back pain. In my words, this is like for people with low back pain, what MRI findings are predictive of long-term disability? So this study, as I said before, was a cohort study looking forward 13 years, comparing their data. And this is really a spin-off study from a randomized controlled trial that the same group of authors started in 2004. Their initial data collection was from 2004 to 2005. Unfortunately, they refer back to other papers for some of the methodological portions of this study, so they don't document their inclusion or exclusion criteria very clearly. And follow-up exclusion criteria is not documented very well either. But you can see there's about 290 people initially included in this randomized control trial. Some patients were excluded for a multitude of reasons, and then they had 204 patients that ended up getting a lumbar MRI. And then 13 years later, they had 170 patients still in the study responding to their questionnaires, and so that's about 83%. The patient-reported outcome measures that they looked at was the Roland-Morris Disability Questionnaire, the Low Back Pain Rating Scale, Numeric Rating Scale, and they did that for back pain and leg pain. And they looked at smoking, smoking status, BMI, any kind of physical activity the patients do, antibiotic usage, spine surgery. They asked the patients about any pain medications they take and any sick leave that they do every single year due to their back pain. The statistics were pretty standard. They used a multivariate linear regression analysis. Their dependent variables were the patient-reported outcome measures that I discussed. The independent variables were things that you could see on the MRI. These were an MRI that was read by a single radiologist. And then the covariates were some demographic data, which I'll show you in a minute. And they used an R-squared to evaluate the goodness of fit, and probability, I'm assuming, was less than 0.05, although they didn't clearly indicate that in the paper. So they used a few different definitions that are important to understand. So the three key MRI factors they looked at was degenerative disc disease, modic changes, and then facet joint disease or degeneration. They used the Furman scale for degenerative disc disease, and that's pictured in the top right here. And anything greater than a grade 3, or equal to or greater than a grade 3 was included. Modic changes, any modic changes, 1, 2, or 3 were included. And the facet joint degeneration, anything grade 2 or more was included. So I told you we had 170 patients in this study, 54% were female, so pretty good mix. BMI was just a little overweight at 27.3. 24% were smokers, 61% married. 11% of the patients ended up getting spine surgery in the course of those 13 years after that initial MRI. And then 65 patients, which is not very clear, used antibiotics. For what, I'm not sure. So out of the 204 patients, 170, which is 83%, completed the questionnaire, which is a very good follow-up for 13 years. 17% did not, and the authors made a point to note that there was no significant difference in these patients, the ones that did not participate after the 13 years, in their distribution of MRI findings, good, bad, or ugly, compared to the other ones that did participate. So they felt it was safe to drop them. And then baseline MRI data, 52% on that baseline MRI had degenerative disc disease, 39% had modic changes, and 82% had facet joint disease. So with regard to the meat and potatoes of the results, the variables with a significant association at the 13-year patient-reported outcomes were modic changes in physical activity, and that's it. So modic changes were predictive of patients doing better, the presence of them. And physical activity was as well. The variables that did not have any significant association were degenerative disc disease, facet joint, smoking, and BMI. And then they also found that patient-reported disability improved over time. So patients that had a 6.2 on the numeric rating scale actually came down to a 4.5 at large. And back pain medication decreased slightly as well from 65 to 56%. So in summary with this paper, the positive predictors of low back pain improvement based upon MRI findings over 13 years were the presence of modic changes, 1, 2, or 3, and the leisurely physical activity that patients engage in on a daily basis. There's no association with long-term outcomes with facet joint disease, degenerative disc disease, smoking, or BMI. So some limitations that I found in this paper were, as I stated before, they used a single radiologist to evaluate all the MRIs. And this leads to potential for bias. There's not much statistical analysis on the variables. There's no chart included in the paper with descriptive analysis. So this made it difficult to understand where some of the data was coming from. And I understand that this is a 13-year follow-up and it's a spin-off of another paper, but it was challenging to astutely look at this. It's unclear why some patients had surgery and how that affected their outcome. It stated that some patients did have surgery, but why did they have surgery? And then were those patients still included in the 170 that were evaluated? I think they were. And I don't know how that skews the data. It's unclear why antibiotics were used because they discussed it. And they said in the paper that no patients had antibiotics for any kind of discitis type infection, but I don't know if there was osteomyelitis type infections or spinal canal infections for antibiotic usage. I'm not sure how that plays into the data either. And then BMI, as we always know, doesn't control for body fat or muscle mass, so it's not the best indicator, but it's the best that we have typically. So data interpretation is a little bit difficult given the data in the manuscript. MODIC 1 progresses to MODIC 3. We know over the course of a lifetime this is probably what's going to happen. Things fibrose, the ability for soft tissue to herniate or to tear decreases and this decreases pain. So this supports that. Physical activity is well supported in the literature at decreasing disability. And this literature, so this paper supports that. And I'd say that doing longitudinal data collection is very difficult and doesn't happen very often. So it's always appreciated when you see a long-term paper like this.
All right, great. Thank you so much. Any questions from the panels?
I'll take a lead on something. So Brian,
Please.
the key point that I wanted to make first about the antibiotics is you're too young to know that. So speaking as an older guy, there was a major publication from Denmark about 25 years ago that had sampled disc tissue and identified nosocomial infections, I think strep variants in the disc spaces. So the thought was maybe just like the Heliobacter causation of stomach ulcers, there might be a nosocomial infection as the cause of, I'll call it virulent, back pain, discitis, undue disc degeneration, chondrolysis.
Okay.
So I assume, and I'll ask Dr. Weichert for his perspective because he's in my generation also, that this might be a residue of the old Danish thought that this kind of a discitis origin of disc degeneration could be a role in this. I'm not sure. Karsten, what are your thoughts on that?
Yeah, that's what I came across as well. And this argumentation makes sense to me that this is sort of some leftover protocol of people who had this in the beginning. What I found interesting, I mean, we always find degenerative changes in the MRI, and the patients always ask us, well, what does that mean? Is that good? Is that bad? And what will that do to me and my condition? And in this context, I found this article, as diverse as the findings might be, rather helpful to see, okay, you might have facet joint changes, but they do not affect any long-term disability. And your modic changes might even be good for your disability perspective in the long run. And so that's an information that can be very helpful for the patients. At least that was my takeaway from the study.
So in principle, this is very reassuring, right? I mean, the general concepts of rehabilitation and being proactive about one's health really seem to be very well manifested in this.
Yeah.
So, Dr. Anderson, this is not known to you, served with distinction in our U.S. Air Force for a very long time, and you were in charge of a lot of service personnel. What did you do in terms of service personnel that would come to you, usually young and healthy, with back pain? Is an MRI scan a normal assessment tool for that, or what's going on?
No, we didn't. And it was actually something that we tried to avoid because my patients, a large portion of them at least, were fighter pilots. And so if you found reasons for a pilot to maybe not be safe to fly, then the patients, which were pilots, were not allowed to fly. And so a lot of times pilots wouldn't come in with a lot of their complaints, but they would say, I'm feeling something that's bothering me. and what should I do to make this better? So I am highly biased based upon my previous role as a flight surgeon, but we did a lot of physical training and physical therapy to combat their symptoms. So the physical activity that this paper's alluding to, which they didn't describe very well, but for my patients, that meant going to the physical therapist, focusing on a structured home exercise program, which really was involved with them going to a very specific gym that we had on base that was dedicated to pilots. And they had strength trainers there. They had people doing soft tissue needling, things like that, to help relieve a lot of what was muscle spasms. But I'd say in a very small subsection of my patients, I did get MRIs. Sometimes we did find things. Sometimes it did preclude their ability to fly for a period of time. Sometimes it required surgery, but those were rarities. Anyway.
I want to take that occasion to thank you for your service, by the way. So
So
the question I have for you, Karsten, in Germany, is, and then we'll have to go on to the next article, because on a tight timeline, we have 4 great presentations of articles. In the US, and I think I can speak for our LA colleagues also, our patients have full access to the medical records nowadays, and they read the reports on the MRI scans, and our radiologists do a really good job in high detail identifying things that are wrong, like what Dr. Anderson showed. And that leads to a lot of concern. There's an undeniable adverse psychological effect, a burden of disease that is inferred by the interpretation of diligent radiologic diagnoses. What do you think?
Absolutely.
Fact in Germany?
Absolutely. And that is, it's the same here, and it's proven, and it's also published. I know the group from Frankfurt, they have looked into this about patients' behavior, hearing about their findings from the radiologist versus hearing about their findings from the spine specialist. And it's a 180-degree difference, really is. And yes, it causes fear, it causes anxiety, it is absolutely helping their chronification process. And of course, it's a radiologist's job to describe everything in great detail, but to really have it in as just one piece of the puzzle, it's important. And what Dr. Anderson just said is absolutely spot on, and that's the way it should be dealt with, that the majority of people do just fine. However, in our medical legal environment, it's in the States much worse than it is here in Germany or in Europe. Almost everyone gets an MRI eventually, and sorting that out and putting that in the right perspective is sometimes not that easy. Yeah, so happy to move on, and I want to call upon Dr. Davis, telling us about the study on non-invasive treatments for failed back surgery syndrome, systematic review. And yeah, looking forward to that study.
Okay, this was the title image of my study. It was the titled Non-Invasive Treatments for Failed Back Surgery Syndrome, a systematic review out of Rome, Italy. And so first we'll start by agreeing upon a definition for failed back surgery syndrome, which is a surgical end stage after one or several operative interventions on the lumbar neuroaxis, indicated to relieve low back pain, radicular pain, or the combination of both without any positive effect. Important to note, 10 to 40% of patients experience recurrent or persistent low back pain with or without leg pain after a technically successful spine surgery. This was a systematic review of randomized controlled trial or observational studies. The inclusion criteria for this study were patients with failed back surgery syndrome who had epiduroscopy, epidural injections, or spinal cord stimulators with high and low frequency stimulation. And the exclusion criteria was patients who underwent any sort of pharmacological treatment, secondary surgical treatment, or patients who underwent multiple non-invasive treatments. At the conclusion of the data collection, there was 1,063 total patients with an average follow-up of 7.6 to 192 months, and the average age of this patient was 45 to 62. Back pain was assessed by the visual analog score, the numeric rating scale, or the Dulier neuropathic in 4 questions. In the Euro Quality Visual Analog Score. And then the leg pain was assessed by the Visual Analog Score and the Neuropathic Pain in 4 Questions survey used in Italy. And then disability was assessed by the Oswestry Disability Index. So in the clinical findings, they began by discussing the benefits to back pain of high-frequency stimulation using spinal cord stimulators, and they found ubiquitously higher relief than low-frequency stimulation. And then one individual study also showed that burst stimulation had a greater relief than even high-frequency stimulation. When they look at leg pain, they similarly found a general agreement that there was greater relief in high-frequency stimulation than low-frequency stimulation. And then regarding disability, they showed that all spinal cord stimulation protocols showed an improvement in disability scores, with one showing an improvement in high frequency. They did mention, without giving incidences, the complications associated with spinal cord stimulators, most of which are hardware related. There's going to be infections, pain from wound complications, and then obviously complications with the leads. They briefly discuss and include in the inclusion criteria things such as hyaluronic acid and corticosteroids, as well as epiduroscopy. They talk about the theory of hyaluronic acid being potentially able to lyse epidural scar tissue and creating a space for other medications such as steroids to reduce fibrosis and combat inflammation. And they posited a possible concomitant effect between the two of these, but they didn't demonstrate that with any of the studies that they included. They do talk about in the discussion that some previous studies that showed that hyaluronidase can improve pain scores, but then and then also another one supporting concomitant effects building on one another, reducing back pain and inflammation with both. Then they also, giving the converse view, this is controversial and not at all clear. They talk about a study from Heavner et al., who compared epidural saline plus hyaluronidase to saline alone, and they did not show any significant differences in clinical outcome. And then they don't note any adverse events or complications occurring in the patients who underwent epidural steroid injections, while only a low percentage of patients with spinal cord stimulators reported complications. So my final thoughts on this paper: I always love these papers that summarize non-operative measures, but I would frankly be a little bit critical of this paper, because in the clinical results and outcomes, they only discuss spinal cord stimulators. I think if you want to have a systematic review about spinal cord stimulators, that's great. I would just like to call it what it is. The inclusion criteria, including epiduroscopy, the words epiduroscopy are not mentioned anywhere in the results at all. They're mentioned in some of the studies on the tables. There's no clear results. There's really no clear results on the steroids or the hyaluronic acid. And then, and so I don't really feel like these studies really got to the meat of the issue. And part of the problem, which does limit a successful study, is they couldn't have any concomitant surgery or pharmacological treatments. And I just think that when you look at back pain in particular, pharmacological treatments doesn't just mean opioids. There's a lot of multimodal things that can be utilized. There's multiple international organizations like the Canadian Pain Society and the NICE organization who have made recommendations that were cited in this paper regarding spinal cord stimulators, but they also make several recommendations regarding cannabinoids, gabapentinoids, topical treatments, antidepressants. And so I think that really, while the main takeaway from this paper is that if you're going to use a spinal cord stimulator, a high frequency is probably better. And I think that's a really reasonable point to make. But as spine practitioners, we also need to be open to the non-opioid treatments. So.
All right, passing off to Hamburg.
Gotta unmute myself here, sorry for that. Thanks for that presentation and for your thoughts on the paper. And I think you've highlighted some of the key issues there. I mean, that term failed back surgery syndrome in itself is faulty and has a lot of controversy implied to it. And we all know that if we are able to find the exact source of persistent pain, then it's obviously a lot more effectively to be treated than if we do not know where it actually comes from, and that can cause some frustration. The reason why I picked this paper is basically twofold. One thing, and I'm happy to give this comment, is that it really shows that we run the risk of comparing apples and oranges here. And if you look at different treatments, if you look at different entities that all are summarized under some sort of vague term, you end up with a study that doesn't really help you with your individual patient's decision a lot. And this is really a call for action to, if you do a study on that topic, to really be as precise as possible and to make sure that the patient characteristics and the pathological findings all add up. And the second thing, obviously, is that we do have a situation where patients who have been through a number of surgical interventions are at a point where even if they might make sense, they just decide against it. And then we, as spine practitioners, are under the pressure of providing some solution for the patient that is non-surgical, if the patient demands that and would opt against another surgical procedure. Jens, what are your thoughts?
We'll have to pass on to over to our LA colleagues who are patiently waiting, but I wanted to add something to it and ask your perspective, Karsten, and maybe also tee that off to our LA colleagues. What I struggle with is there's no question that dorsal column stimulation has been a very meaningful addition in our arsenal for pain management for certain patients. Emphasis on certain. So certain neuropathic pains, it's really just evolving even, and it's really kind of cool to see. The problem that we see now is being used as a blanket therapy for anybody who has something going on, even in patients with severe structural problems. Clearly surgically treatable conditions, like a bad stenosis, they get dorsal column stimulators, and then the initial trial phase, which is supposed to weed out the responders to non-responders, usually is not followed with a good success when the actual implant is in disappointment. So the point is undifferentiated use and use in patients who clearly have a structural problem and mechanical back pain and stuff like what Dr. Anderson talked about, patients who should be in rehab and not just turn on an electrical buzzer. Is overuse and undifferentiated use a problem in Germany, Karsten?
Yeah, I mean, it's the same over here, and the patient's decisions and the treatment decisions are taken in the very similar manner here. It's becoming more popular, and the body of data is promising. However, you need to pick the right tool for the right patient, and you need to be open. And if you only have 3 things in your arsenal, you are going to fail, no matter be it surgical or non-surgical. Yes, well, thanks for that, and thanks for that summary. And I'm happy to move on and look down further south to California to Dr. Eng, and telling us about a study characterizing Gabapentinoid use among patients with isolated low back pain.
All right, good morning, everybody. Let me get my window shared here. Are you seeing it okay? All righty.
See you.
I will be presenting this study. No disclosures from me. Introduction to this study. So low back pain is a leading cause of disability worldwide. And especially more recently, there's been an emphasis on minimizing narcotic prescriptions in the setting of the opioid epidemic. Literature does support the use of gabapentinoids for neuropathic pain, radiculopathy, and postoperative spine pain. However, there are multiple studies, meta-analyses, and randomized controlled trials that have shown that gabapentinoids are not very effective in reducing pain or disability in patients with isolated low back pain. So the goal of this study was to further characterize the use and predictors of use for gabapentinoids for isolated low back pain using a large national administrative data set. The study population comes from the M91 Ortho Pearl Diver data set, which includes 91 million orthopedic patients. Inclusion criteria were low back pain diagnosed between January and December of 2019 using the ICD-10 code M54.5, which is just low back pain unspecified. Patients also had to be active in the database for at least a year. Exclusion criteria included diagnosis of radiculopathy or sciatica, history of spine surgery, any lumbar vertebral fractures or conditions for which gabapentinoids are actually FDA approved, including epilepsy, post-herpetic neuralgia, diabetic neuropathy, fibromyalgia, and spinal cord injury. After meeting these criteria, there were 1.15 million patients included in this study. The outcome variables were new gabapentinoid prescriptions within 1 year of low back pain diagnosis, and they were analyzed for incidence of gabapentin and pregabalin use, incidence of gabapentinoid use relative to narcotics, as well as prescriber specialty. And the patient characteristics that they assessed were age, sex, Elixhauser comorbidity index, which is a measure of overall comorbidity burden, geographic region, as well as insurance type. So results of this study, of the 1.15 million patients included who had isolated low back pain, there was 11% of them were prescribed gabapentinoids, 8% of them were prescribed narcotics, and 3% were prescribed both gabapentinoids and narcotics. The most sort of salient point here that they noticed was that prescriptions for gabapentinoids are primarily coming from primary care physicians, consisting of 45% of those overall prescriptions. So here's some tables with their results. I'll try to pare it down a little bit, mostly focusing on table 2, looking at their multivariate analysis of predictive factors for gabapentinoid prescriptions. They did find that independent predictors of gabapentinoid prescription included age. So with every 10-year increase in age, there's an odds ratio of 1.06. Female gender was predictive with an odds ratio of 1.1. 2-point increase in ECI was predicted with a odds ratio of 1.24. Geographic region, with the highest odds ratio being for patients in the South, and then insurance type with Medicaid having the highest odds ratio. So limitations of this study, it was a large database study, so it's limited to the accuracy of the findings, or limited to the data that is coded in that database. We're also unable to assess the chronicity of symptoms based off the data set. And then it's also possible that neurologic symptoms couldn't really be excluded, despite the patients potentially having it, just based off of the administrative coding in the study itself. And that's it.
All right, great. Thank you very much. Any questions from the board or from the audience?
So this was a great topic again, and it is so important that we somehow figure out an alternative to opiates, and we in the US are the world leaders of opiate prescriptions. I'm not talking about illicit opiate use, but opiate prescriptions, and it's a real issue now. We have another medication category, the membrane stabilizing gabapentinoids, to assess, and really important with all the known limitations of large database assessments to try to wrap our head around why some of those things that we're seeing are happening. So I'll just put it to Dr. Eng. So why are we seeing this preference for Medicaid patients, which for those who don't know that in our international audience is kind of our basic insurance plan. So this is people who are not employed and who are under 65 years of age and are disabled or whatever. Why is this so common there? Is this just a reflection of the disability status? Are there any social preferences? Is there an attempt at mediating the higher opiate use in this population? Any thoughts, Dr. Eng?
They didn't really touch on it much in the actual paper itself, but I do think it has potentially multiple factors, both social and potentially that the Medicaid population could potentially have a higher sort of disability status and overall burden of disability. I think that certainly has a contribution to it.
What
We
if
know. Sorry, yeah, go for it.
if I may chip in here, what I really found interesting is that, or actually, I wasn't quite sure if I wouldn't have been disappointed at 14% of patients getting prescribed a medication that knowingly doesn't work for their condition versus 85% who did not choose that medication. I don't know if I see the glass for half full or half empty. And the other thing, I was wondering whether that's actually a typical US problem. I mean, Gabapentinoids for low back pain, that's off-label here in Germany as well. We all know it doesn't work for low back pain. We know it works for radiculopathy and these things very nicely. But I couldn't even think why to describe this to someone. And then seeing the summary of the authors saying the patient characteristics were predominantly non-clinical factors, that makes it even worse. From an international perspective, I have no idea why that was chosen.
So let me pass the microphone off to a very special guest I did not introduce earlier. Dr. Emre Ilmaz is actually from Germany also. He's an Oberarzt, a chief surgeon in a large university hospital system, and it's the BG clinic. He's also deputy editor of Global Spine Journal, and he's here in his capacity as AO Spine International visiting fellow. Really a big honor to have him here. He is in charge of a very large workman's comp population. This hospital is a center of excellence in the German BG system, so the disability workman's comp system. What about a large controlled system like yours? Is there a better control of how prescriptions are handled for patients with back pain?
Good morning, everybody. Thank you very much for the introduction. Moin Moin nach Hamburg. I think it is actually because we have the capacity to like follow up the patients on a like short-term notices and giving them strict regimes in terms of physical therapy and having a closer look on their medications. But like, yeah, I think it's like Karsten said, like there are huge differences in terms of prescription of medications in Europe, especially in Germany compared to the US. And I don't know if that is one of the biggest relevant factors in here in this regard.
So a really important topic, so structured pain management. And again, for me, one of the big concerns, and I'd be curious to hear the LA perspective also here, is we are practicing more and more checklist medicine in an algorithmically dictated fashion. So we all have large electronic medical healthcare systems, and any activity, anything that we want to do, we have to show that patients have done certain things. We obviously try to meet these expectations of our insurance companies by always modifying our electronic medical records. So one of the check boxes is that they've tried non-opiate therapies with non-steroidal anti-inflammatories, and one of them is membrane stabilizers. It's not differentiated. And if we've not checked those boxes, then any interventional therapy, whether it's an injection or surgery, is basically denied. So checkbox medicine, is that a factor now? And is this a side effect of this? Maybe Dr. Eng or your colleague Josh can talk about it briefly. Is that why we're seeing this more and more?
Well, I think that does have something to do with it. I also think looking at this study, seeing that most of these prescriptions are coming from primary care providers could potentially just be that these primary care providers are, one, not in-depth trained in sort of spine pathology. My wife is actually a primary care provider, and I talked to her about this study and how she felt about it. A lot of it, I think, comes down to feeling like they have limited options to prescribe these patients at this point. A lot of them have medical comorbidities that prevent prescription of NSAIDs. Obviously, they're trying to decrease prescription of opioids. And it just may not be very well known amongst the primary care community that gabapentinoids aren't particularly effective for low back pain.
Let me ask one of our fellows who's really worked in this also. And by the way, I want to point out Dr. Davis is going to have a nice paper on medicational management of back pain coming out in the near future. Dr. Neil Patel, if the camera can go towards me, sitting right behind me. Are there any sensible medical adjuvants or synergistic effects that are underutilized where using gabapentinoids might actually be sensible?
Hey guys, yeah. So I believe that I like to use duloxetine, Cymbalta, in addition to gabapentin for synergistic effects on nerve pain. And there's a lot of research on this in terms of potentiating gabapentin, and patients can be on lower doses of gabapentin with duloxetine on board, and that also changes kind of their ability to think of pain. And we've looked about this in the past as, you know, when you ask patients a year out that would they get the surgery again, and the biggest things that came up were anxiety and depression. And people who were diagnosed with anxiety and depression said they wouldn't get this surgery again, or spine surgery again at 1 year. So if we can give them medications that kind of change those disease or at least alter those disease pathologies, then maybe we can improve outcomes, or at least how patients think of outcomes, and have a successful life after that.
Karsten, what do you think about that? So adding a antidepressant towards what's, at least here in our country, we see so much as a comorbidity, depression and anxiety.
Yeah, I mean, it's a well-known comorbidity, especially with chronic low back pain patients. However, yes, we do know the effect that potentiates the treatment capabilities of gabapentinoids, but only for some neuropathic pain, but not for chronic low back pain in a way. So yes, this medication can be used in combination with other substances and make some sense there. I personally always go more towards a training, rehabilitation, and stabilization aspect, and less than a pure medication solution for these chronic low back pain patients, because that's usually frustrating, or often enough frustrating. Anyways, we're...
One second. I have one comment.
Yes, sorry.
From Dr. Patrick Pritchard. He's a famous, well-known neurosurgeon. Good morning, Patrick. Always an honor to have you here from the University of Alabama, Birmingham. So good morning to you, sir. And he identified one of the main problems, and this can be a good segue for the next paper also, gabapentin dosing. Too often, patients and physicians abandon if low doses don't work or the titration is not handled properly. They get, quote, allergies to gabapentin or feel sick or too drowsy. So dose effects are important, right, Karsten? So dosing properly, titrating it up and down. And he thinks 1,800 milligrams a day might be an effective dose, but you have to work towards it. So it's, again, a lot of work effort to make that medication possibly work and not have side effects. Thoughts on that?
Yeah, so well, you have to stay on top of your patient and have to really guide them along and monitor these things closely and see how far you can take it. But the dosage obviously has to be high enough, and has to be high enough for a substantial amount of time. And I really agree with him. And that can be challenging. To logistics, to the patient's motivation, and also to the doctor's motivation as well. And yes, those are just complicated people.
I would, on that topic, I would just add that we do tend to, at least here, go to gabapentin before we go to pregabalin, and the reasoning just being a pricing issue. But I think that understanding that the bioavailability and the predictable dosing of pregabalin is actually much better. And so several of the international pain societies have recommended a dose of 75 milligrams for pregabalin. And as much as we love to make sure our patients can get the drugs they need at an affordable price, I think that the benefits of Lyrica would make it a more lucrative first-line choice for patients who have the means for it.
I agree. Okay, cool. And then we're on the final stretch of this Journal Club morning or afternoon, as we can say here in Europe. And I'm happy to introduce Dr. Josh Peach again from USC. He's telling us about treatment efficiency, clinical utility, and cost effectiveness of multidisciplinary biopsychosocial rehabilitation for chronic low back pain patients. Please.
All right, good morning, thank you. Let me just share my screen here. All right, good morning, everybody. No disclosures. So the article that I will be presenting, it's called the Treatment Efficacy, Clinical Utility, and Cost Effectiveness of Multidisciplinary Biopsychosocial Rehabilitation Treatments for Persistent Low Back Pain. And this was a systematic review out of Switzerland. So as a bit of an introduction, the authors note that non-specific low back pain has a lifetime prevalence of up to 84%. And they define non-specific low back pain as back pain that doesn't have a structural origin. They also note that this is a significant cause of disability, economic burden, reduced quality of life, missed time at work. And another important thing to realize is that low back pain can have multiple different causes. These can be physical, psychological, social, genetic, and even having cultural components as well to it. And the utility and cost effectiveness of various treatments for low back pain is not well defined at this time. And that's sort of what the authors wanted to delve into a bit more. So looking at this idea of multidisciplinary biopsychosocial rehabilitation, or MBR for short, the authors do define this pretty well in the paper. And they base this off a previous definition by a paper by Camper et al. And that is basically interventions that involve at least two of the following components. So those can be physical, psychological, social, or work-related factors. And also interventions which include a therapeutic team that has at least 3 different healthcare professionals that communicate extensively about the patient's care. So this can be physicians, physical or occupational therapists, psychologists, anything of that nature. Also, the therapy needs to be high intensity. So for the purposes of this paper, they were looking at MBR therapies where patients participated at least 25 hours per week. And also this should include some type of cognitive behavioral therapy as part of the program as well. So with all that in mind, the principal aim for this paper was to evaluate the efficacy, clinical utility, and the cost effectiveness of these MBR treatments for persistent low back pain and non-specific low back pain. So for their methods, the authors performed a systematic review. They looked at Web of Science, Cochrane, PubMed, Embase, and PsycInfo. They did follow the PRISMA guidelines for this systematic review, and their inclusion criteria is pretty specific. They used patients that had persistent back pain, so that was at least 12 weeks. MBR interventions that included cognitive behavioral therapy, again, for at least 25 hours of treatment per week, and at least 3 healthcare professionals had to be involved in the care. To look at the quality of evidence of each of the studies they included, they did use the GRADE approach. So looking at the results, this is their figure 1. So their initial search found about 1,200 articles, and ultimately they narrowed this down to 13 studies to include in the final analysis. This included 4 randomized control trials, 6 prospective studies, 1 retrospective review, and 2 cost analyses. Looking at just some of the baseline demographics, so again, 13 studies were included, and this ultimately had about 2,000 MBR patients and 947 controls. The average age was 43 years for the whole cohort. 49% were female, so a pretty even split. And the range of therapy hours per week was 25 to 50 amongst all the studies. Looking at the overall study quality based on the GRADE approach, I think this is an important table that they included here. This is their table 2, and I kind of starred a few of the important columns look at here. So looking at the overall limitations of each of these studies, essentially most of the studies have very serious or serious limitations based on the grade approach. Looking at imprecision, similar, they found serious imprecision in quite a few of the studies, publication bias in a few of the studies, and then looking at the column on the far right, just the overall quality of the 13 included studies was mostly low for all of them. One study was moderate and one study was high. Looking at the results that they delved into, so looking at pain intensity specifically, 8 studies did assess pain, looking at 12 months following MBR treatment. These studies did find a moderate to large effect size, as well as significant pain reduction pre versus post-treatment. And they also showed that this reduction in pain did persist for at least 24 months after MBR treatment in the studies that had longer follow-up, out to 2 years. Similarly for disability, 8 studies again assessed this using a wide variety of instruments. Again, all the pre versus post comparisons showed there was a moderate to large effect size and significant values for reducing disability in patients who did the MBR therapy. And again, this was seen out to about 24 months in studies that had the longer follow-up. Looking at the results for health-related quality of life, these were a little bit more inconsistent. There were 7 studies that looked at this, again, using a variety of different instruments and patient-reported outcomes. Essentially, 3 studies found there was no difference in long-term health-related quality of life. However, 4 studies did find a moderate to large increase in health-related quality of life that persisted to about a year after therapy. Looking at cost effectiveness, 3 studies looked into this. All these studies did find that MBR therapy reduced the direct and indirect costs in the short term, so within the first year. For example, Bush et al. Found that there was a cost reduction about 3,583 euros per subject. They projected this out to a reduction of about 53,000 euros per person over a 10-year time period. However, the results are a little bit less clear after a year. There were some studies that showed that after a year, it did not become cost effective and everything sort of evened out. So a little bit inconsistent in the long-term results here. And looking at workability, again, the results were a little bit inconsistent. 11 studies did look at this. Essentially, they all found that there were moderate to large effects on returning to work, duration of 6 days. Again, in the short term, so within the first 12 months of doing MBR therapy. But the issue again was in the longer term follow-up periods, the results were conflicting with essentially some studies showing there was a benefit and some studies showing that after 12 months, there really was no difference between groups. So I think the overall strengths of this paper, it's a systematic review, so it's combining a lot of different literature together to try and get a better picture of what's going on here with persistent low back pain. They did follow the PRISMA guidelines and use a grade system, which is helpful. And they did have a strict inclusion-exclusion criteria for MBR, and they defined this well. I think the biggest limitation is probably the quality of included studies, which I mentioned earlier, which is mostly low. So I think you do have to take this into consideration when you're looking at those results and applying it to your own practice. And then the other thing to point out is just kind of the overall utility or practicality of getting patients to do 25 hours a week of therapy. I know for a lot of people that could potentially be a limitation of sort of taking this MBR type treatment method. So in conclusion, the authors found that MBR is likely beneficial for reducing non-specific low back pain and disability and is likely cost effective within the first year. But I think longer term outcomes, specifically in cost and return to work, do need some further investigation and some higher quality studies. Thank you.
All right, thanks. I think you summarized the key points very nicely. Any questions from the board?
Yeah, so here in Seattle, we have probably some legacy here. The original multidisciplinary pain center was founded actually at the University of Washington by an anesthesiologist named Dr. Paul Bonica, B-O-N-I-C-A, and was continued on with a neurosurgical colleague, John Lozier. And it's very sad to say that in the founding place, and I saw the miracle of what happens when you put patients literally out of their normal lives as an inpatient into this kind of a program. And I saw it emerging. That's a multidisciplinary effort. It was shut down basically because of its cost. It's just over 2 decades couldn't function anymore. So I have no doubt that getting people out of their usual quagmire due to the multitude of problems that they're enmeshed in, and reprogramming them works. But the cost and the societal impact was just not tenable. I don't know how that is in Germany. Do you have a program like this that's sustainable?
Yes, absolutely. And this is why I picked this study, basically for two reasons. But for one reason, and that was quite close to me, because the program I chair here in Hamburg is doing exactly that. It was founded about 20 years ago. And we had patients who had been on sick leave for a significant time, and who were on the verge of basically getting their financial situation changed. And they were identified by the insurance companies, and they enrolled these patients into the program. And the program basically made sure that they went back to work. And it's a 100 hours program. It's 4 weeks straight, and people, like you said, they come in the morning, they go home at night, but they cannot work at that same time. So they're not employed, or at least not working at that same time. But the likeliness of them going back to work is well above 90% at the end of this program. And we're speaking about chronic low back pain patients. And actually, I mean, it's probably the same in Europe than it is in the States. But the only thing the insurance companies care about is get them off their back and making it as cheap as possible. And these programs, they do work. They work nicely. The follow-up costs are a lot lower. And up to this point, we have had a very close relationship with the insurance companies in this, and they're very happy about the results from the economic, but also from the medical perspective. So this is proven and it works, and that is also from the financial perspective quite helpful. Plus the clinical benefit.
If you put a hat on being an insurance commissioner or a president of a commercial insurance outfit, would you support, based on this article, a multidisciplinary rehab program, or is it what's the gist of this article? Is this in favor?
I would support it. I would support it hands down. No, not a second thought, because financially it makes absolute sense. Yeah, these people go back to work. At least in our healthcare environment, the chances that they get back to work are just so much higher, and the financial implications and the follow-up costs are, compared to any type of surgical interventions, much less any type of ongoing heat pack massage type of treatment and being on sick leave forever is just so good. We have not had one single bill that was not paid by the insurance companies in 20 years, and we had no single contract that was ever terminated by them, because it simply works from the economic perspective.
I have no doubt that if you take a big picture perspective, this works. And I told you before, Josh, for us, at least here in the Northwest, it's all procedurally based now and short-term perspectives, like 3-month perspectives. How's it from your perspective in LA and in the market where you'll head as a spine surgeon coming this summer?
Yeah, I would say probably pretty similar. You know, we are doing short-term things like injections, physical therapy, things like that for a few months at a time. But I do think, you know, this article, I do like the idea that they do look at longer term. They're looking at year, 2 years, return to work. I mean, these are things that, you know, affects a patient's whole life. So I do think that's important and does have a lot of value. So I think this does have some merit to it, I think. It just, I think getting patients to dedicate that much time a week is obviously a commitment. So I think you have to have a motivated patient and things like that. But I do like the overall gist and idea of it for sure.
We're at the full hour. This was our second Global Spine Journal Journal Club, and this was live from Hamburg, not live from Seattle. Karsten, final words of wisdom, final conclusions?
Yeah, well, thank you to all the panelists. Thank you for the work in summarizing these papers on a variety of non-operative topics. I think they're quite relevant, and I hope everyone in the audience got something out of it for their daily and clinical decision-making and their lives. Thanks to the Seattle Science Foundation. Make sure everyone can get their CME for this event. Thanks for hosting this, and yeah, I'm happy to put a little teaser out that the next Global Spine Journal Journal Club will be coming up next month.
All right, guys, take care. Good to see you.
Bye-bye.